First of all, I'd like to thank the organizing committee and Yannis and Witzke particularly for including me in this panel. I'm very grateful to have this opportunity, but I'm less thankful with the topic. I initially thought, that's straightforward, it's very easy, how do I do revision surgery? But then I found out that I had major problems to define the concept of recalcitrant chronic rhinosinusitis. I would probably agree that a patient with a recurrent polyposis after Richard, after Witzke, after your surgery comes back with polyposis, we can say surgery was done perfectly, and that is a recalcitrant one because it came back after a good surgeon, or what I believe is a good surgeon, has done that. But that is not all. Richard has already mentioned a couple of these things, and when it comes back to recalcitrant, I check the dictionary here, and you see that mainly we mean uncontrollable or out of control or things we cannot manage. The EPOS, as you have stated already, has mentioned their definition, but that is only a frame. There is no content to that, and I have checked literature, and everybody publishes about recalcitrant, but there's no definition of recalcitrant. That's strange. You put some balls on the tee, as you have mentioned, because you mentioned a couple of things. So the first thing is, my proposal is to perform in the near future a modified Delphi questionnaire to involve the experts to get this thing defined, so that we're talking exactly about the same issues. So, do we agree that we mainly say recalcitrant for chronic rhinosinusitis with polyposis, plus minus asthma, plus minus non-steroidal anti-inflammatory drug, exacerbated respiratory disease? Are there more things to it? We will see. We'll check that in a minute. So primarily, when we talk about chronic rhinosinusitis that may become recalcitrant, I would say that we have the type 2, the red one should be above, and the next red one here in type 2 inflammatory disease. Yes, we can have a dentogenic recalcitrant, but usually this case are cured with a medial maxillectomy. So is that really a recalcitrant? So I'm not sure. I would say recalcitrant, it comes back despite medical or despite medical plus surgical treatment. And more important is, what is the disease severity and burden that the patients do have following the EPOS document? There are more associated things, and this is something we have to consider when we talk about recalcitrant. It is not just having a high Lund-Mackay score or modified Kennedy-Lund score. That's not everything. It's the SNOT-22, it's what the patient is suffering. We do not do surgery on X-rays, we do surgery on patients. And there we have to consider their symptoms, of course. So again, what is definition of recalcitrant chronic rhinosinusitis with nasal polyps? We can stick to that. There are exceptions, of course. Well, no response to maximal medical treatment. Whatever that is, that is defined, you check in EPOS. Or recurrent polyposis or symptoms after maximal medical treatment and or surgery. But what can be considered an appropriate surgery to call a chronic rhinosinusitis recalcitrant? We all have received patients referred from elsewhere where we see, the FES was done, but the frontal sinus is still diseased. Is that a recalcitrant? The frontal recess had never been approached before. It's a virgin frontal recess. You do a normal FES surgery and you could. That is not recalcitrant in my hands. It may be recalcitrant for someone who is less expert. So we really need to define the extension of the surgery to see what is recalcitrant or resistant or uncontrollable to our treatment. And exactly when we define that appropriate treatment has failed. So, how many medical series are needed to fulfill this criterion? Or how often does the patient need to undergo surgery to say, okay, this guy has a recalcitrant chronic rhinosinusitis? That depends, of course, on the extension. And again, you look into the literature, and nobody does explain the exact extension of the surgery applied to patients with so-called recalcitrant chronic rhinosinusitis usually with polyposis. So it has not been defined how often surgery has been performed and to which extension. So I have to insist on that. And there are different definitions for the extension of FES. We had that already. Simple aerating, ventilating procedure, or polypectomy, classical FES, extended FES, plus minus draft. Which one? 2A, 2B, 3. That has not been defined. So what is failure after which type of surgery? And there are a couple of factors you already have addressed, Richard. I appreciate that because that saves my time. Is radical FES the nasalization introduced by the French, or the so-called reboot technique, or the mucosal regeneration or replacement? Are these surgeries that have been considered for recalcitrant? Will that change the outcome on the long term? We do not know. I will show you a couple of results and see that we are still at the beginning of that. So when does the surgeon say that we have had maximal treatment plus minus surgery? And that is the issue. That is not defined in the papers. When there is recurrent polyposis, grade 3 or 4, or polyposis only, does the patient have asthma? You mentioned already all these avenues leading to the Arc de Triomphe, non-steroidal anti-inflammatory drug exacerbated respiratory disease, local eosinophilia, you mentioned that already, immune problems, biofilms, plus minus Staph aureus involvement. Are these all factors that may have an influence of what may become eventually a recalcitrant osteogenesis, you mentioned, as an expression of chronic osteitis? However, that is an interesting finding when you see this type of image in the CAT scan. You do not know, or never know, whether this is still an active or a non-active osteitis. You don't know that. You see that there is effect on the bone, but you don't know whether it's still working. And when the Land-Mucosa score is high, or when the SNOT 22 shows that there is a major burden for patients. So that is not being defined. So that makes it very difficult for me to define what is the correct type of surgery. So we go back to literature. And this is all this magic figure about 20% recurrent rates in chronic rhinosinusitis. Well, that depends. If you're dealing with a chronic rhinosinusitis without polyposis perhaps, or with a normal disease, that may be true. But when you're dealing with all this big issue that includes biofilms, Staph aureus, asthma, non-exacerbated, and so on, that figure is probably much higher. Much higher. So that leads us to a group of patients that is completely different. And that magic figure that was represented in many of papers showing that the FES was working and 80% were cured, that depends on which patients you're doing surgery upon and whether these then became or not recalcitrant. And also, if you look into the papers, there is not always a good differentiation between chronic rhinosinusitis with or without polyposis. Check that in the literature. We'll show you a couple of examples. So inflammation type 2, or the endotyping, was not defined 15 years ago. So now we have a little bit more framework to work on, but we did not have that back then. And then again, there was no differentiation in the extensions of FES when you read the papers. So again, no study of the time of interval between surgery. Now we have one, come back to that in a minute. And there's no study about the timing of FES. We have now one from Claire that was mentioned by Richard already. It looks as if the early we attack surgically the patient, the outcomes look much better. But again, in that group of treated patients, only a certain percentage has chronic rhinosinusitis with polyposis. I will show you that in a minute. So, this is the paper I mentioned, that does time to endoscopic sinus surgery impact outcomes in chronic rhinosinusitis. This is a prospective study by well-known authors I admire. It is an audit to study the impact on the delay from diagnosis to surgical success. And it showed up that first-time patients were included and grouped based on the time it took to perform the surgery. There was an early cohort, but see the early cohort, there's only 67% of chronic rhinosinusitis with polyposis. So there is a percentage of cases that had no polyposis, and that distorts a little bit my feeling about recalcitrant group. Okay, these were operated upon less than a month after diagnosis. Next one between 12 and 60 months. Again, 61% of chronic rhinosinusitis with polyposis. I think it's 39% that do not have polyposis. And then the late cohort, 68% of chronic rhinosinusitis operated upon after 60 months. Yes, we have learned that taking care about comorbidities and the preoperative CT scores that were analyzed for these patients, it showed that asthma and allergies had significantly more prevalent cases in the late versus the early or mid-term cohorts. That means they have more time to become more severe. So fine, do earlier surgery. Late cohort, greater symptom burden, yes, of course. They have a long-standing disease. That is understandable. It's okay. And the SNOT-22 scores, of course, are higher in the late cohorts. Well, I will skip that because the main message was here. Then there was another study in the UK. Usually these are audits. They're very useful because they gather together all types of patients operated by a variety of different surgeons. And that is a real-time analysis of what is going on. And that is what Claire Hoppings did here. And they found out two cohorts, the early cohort. And you see, in the early cohort, there were only 48% of nasal polyposis and 30% of nasal polyposis plus asthma. So it's not the type of refractory or recalcitrant group we were expecting to, but it is giving us an information about the real-time success or results they have. And this group had surgery within 12 months of the first diagnostic of chronic rhinosinusitis versus the late cohort. Here also 41% of nasal polyposis and 16.7 polyposis plus asthma. So it's not exactly the group we are addressing, but it gives a little bit of a sensation of what is really happening. And this cohort was operated after 5 years after diagnosis. They were matched for age, for gender, for asthma, for polyposis. And what was found out? Well, healthcare needs are related to chronic rhinosinusitis were analyzed here after 5 years post-operatively, and patients in the late cohort used significantly more chronic rhinosinusitis-related care than patients in the early cohort. So they have a more severe disease. That is a good argument to have an early surgery for these type of patients. But again, this is a mixed groups, and it's very difficult to draw conclusions for my topic, namely surgery on recalcitrant cases. Oh, I'll skip that here. And then again, the audit on 980 patients on the time from previous surgery that predicts a subsequent treatment failure in chronic. That is a little bit more interesting because this tries to assess which patients derive least benefit from current treatment pathways. And 45.9% had already a previous surgery at the moment they were included in the study before the so-called index procedure. And this group, having a long-standing disease and period, had a significantly higher rate of additional surgery compared to those undergoing their first sinus surgery. And that is a significant difference, as you can see here. So again, it seems that doing an earlier surgery when having the diagnosis is better for this type of patients. I will skip this here. And again, after a multiple regression study, the interval between previous operations was a better prediction of subsequent revision surgery than was asthma. Also, it's interesting to read. And having this non-steroidal reaction and inflammatory disease was the strongest prediction for the need of further surgery. So we have here a clue that leads us to what refractory cases may have or suffer from. extensive surgery was associated with lower revision. Richard, you said that already. You have become more aggressive. We all have become a little bit more aggressive, and we are still struggling about how aggressive we need to be. That is still the discussion we need to go on, because that is not yet clear. Well, I will skip that and talk a little bit about extended surgery in revision phase, because there is a lot of open questions. Should we proceed with a surgery to an endotype-driven care? That means if I have a patient with gathers all the things you have mentioned, asthma, polyposis, biofilms, staph aureus, the NERD, this patient has a mild polyposis initially. Are you treating that because of his endotype is indicating us that he may end up having a refractory, or we do a limited surgery because the extension of the disease is still limited? That is an open question, and that has not been clarified. So does this, in fact, have an influence on the extension of the surgery we are offering these patients? And that is an open question. So we know that chronic rhinosinusitis with polyposis plus the endotype dominance type 2 should be submitted to an early surgery. But what type of surgery? Full FES? What is the definition of full FES? That's different for you, that's different for you, and it's probably different for me. And you go to Australia, and they all do type 3 when they enter the door. So that has not been defined. So that was my issue when I said I was not that thankful to talk about surgery of recalcitrant chronic rhinosinusitis. What about the concept of having new mucosa there? There are a couple of studies there, but they're all pilot studies. I will show them to you. So radical surgery, the so-called nasalization of the French group with Roger Jankowski, head of them, treated patients that had better outcomes the more aggressive the surgery was. Well, we heard that already. I think we have a similar experience, but that does not prevent patient probably to have a recurrency. And that is my main issue too. So the total recurrence rate by Jankowski was 22.7 in the nasalization group. That means full radical surgery, and was double in the normal FES group, the adenoidectomy group. That was statistically significant, but there are more to it. This is the reboot technique published by Klaus and co-workers. The problem here is that the follow-up is too short, and that the basal diseases, as you mentioned there, is different in all the three groups. And basically, what I found out when I checked that paper is that, and we had that discussion in the Dr. Jonstam PhD thesis in the Karolinska, is that the non-reboot cases had a more higher rate of asthma patients. So you cannot really compare that, and that is an initial study. I'm not saying it is bad, but we are just at the start. We need to show whether this is working. Well, a colleague of mine from Seville has published a study of free nasal floor mucosa grafting after endoscopic surgery. That means taking mucosa from the nasal floor and putting it at the ethmoid in order to have a new healthy mucosa substituting the diseased mucosa. That's not a bad idea, and he did a pilot study with only 10 patients published in Rhinology, and he recently published another one in our journal with 10 plus 10 patients, and it looks as if it was better to remove that diseased mucosa and to substitute it with new and healthy mucosa that is not able to transform into polypoid tissue. But this is a study that has only a 1 year follow-up. So we again are at the start. It looks good, but all our other surgeries, as radical as they were, also look good after 1 year. So we need to check that on the long term. And as Witzke said, I think we need a long-term study with a multi-center study with many of us being involved. So my conclusions is patients with chronic rhinosinusitis with or without nasal polyposis that do not respond to maximal medical treatment should be operated upon earlier. That is something we found out. that when chronic rhinosinusitis with nasal polyposis is associated to inflammatory type 2 parameters, surgery should be probably more radical or extended. Definition still pending. We have not exactly defined what that radical exactly means. It is different in your hands, it's different in yours or mine. So that is not a consensus surgery, as I would say. So what is the number of maximal medical treatment series or surgeries that we need to call chronic rhinosinusitis recalcitrant? That has not been defined. It has not been defined the number of surgeries needed and the extension of surgeries needed to call a chronic rhinosinusitis refractory, and whether we have to do it with or without draft type 1A, 2A, B, or 3. That has not been defined. So, and whether recalcitrant chronic rhinosinusitis also means perhaps going back to open approaches to obliterate the frontal sinus. We have to discuss that. Thank you very much for your attention.
Thank you, Manuel. That was really, very interesting with so many questions. We probably need a whole meeting to be able to figure all of these things out. Actually, we don't have too much time for questions, but maybe is there something from the audience? Because I think that an interesting point is, if you have a patient that's a type 2 patient in their 20s, do you do a very aggressive surgery initially then?
No.
No. So.
What do you mean with aggressive?
Yes.
I do a full fest.
Yeah, you do.
And that means sphenoidmoidectomy with large middle metal antrostomy, draft type 1A, and depending on the size of the osteum, I decide whether I go further. But that strongly depends on the symptoms of the patient, the complaints, whether there is facial pain, whether there is sensation of obstruction, how to treat the frontal. In an initial surgery, I would very rarely go for a draft type 2B or 3. Very rarely.
Okay, thank you, Manuel, again.